Davis. She is a nurse practitioner here in the pediatric endocrinology department, and she's going to talk a little bit about transgender and gender patients and care for them here in the hospital.
Thank you. Thanks for having me. It's a little bit early for me, so I'm hoping that this is interactive. Please feel free to ask questions, stop me at any time. Some of these slides might feel more technical than others, and I am going to skip over some things that aren't relevant to this particular group, but please stop me if at any point you have any questions or want to have a discussion about an experience that you've had. So I am going to introduce our program. So I'm Meredith, and I am the nursing director of the Child and Adolescent Gender Center. And we are a collaboration between UCSF, Benioff Children's Hospital, and other organizations, including an organization called Gender Spectrum, which is an organization that it's based in the East Bay, but it provides national services. And what they do is they provide advocacy for transgender, gender diverse kids in schools. We're also affiliated with National Center for Lesbian Rights for legal aid for this population. Mind the Gap, which is a consortium of mental health providers who provide work for youth with gender dysphoria, and some other more community-based organizations. So my objectives for this talk is I'm hoping that you guys will gain a basic understanding of like the language and concepts about gender diversity so that you feel more comfortable interacting with clients who come into the surgery practice. And also that you'll be able to describe some factors that influence the positive mental health and physical outcomes for gender dysphoric youth, and really like what your role is in terms of promoting that. These kids are coming to clinic, they're coming to the OR for various things, whether it's for an appendectomy or gender affirming surgery. And their experience here with the staff is going to be seminal for establishing their comfort with the healthcare system in general. So I think it's exciting to see you here and have your interest. I'm going to go over some basic non-pharmacologic and pharmacologic interventions that we use, more so you understand what these kids might be on, estrogen, testosterone, puberty blockers, these kinds of things, so that you understand what are the potential risks related to surgeries, what are some things you want to think about. And then I'm hoping that you'll be able to identify some of the barriers that these kids face and how we can address them at UCSF. And at the end, I will have some information on the surgeries, the gender-affirming surgeries that are done here at UCSF and in the community. The surgeon here that I work most closely with is Dr. Esther Kim from plastic surgery. She's currently doing chest reconstruction surgeries, and I think she'll also be doing some bottom surgeries at some point. So I don't know if anyone's worked with her before. Has anybody had clients? Okay, so you know her. I have no disclosures. So some basic gender concepts, and please again stop me at any time. Gender can be conceptualized as having three main components: gender identity, assigned sex or designated sex at birth, and then gender expression. And these are all components that go into the general concept of gender. The way I think about it is gender identity is something that you hold inside. Gender assigned sex is something that someone assigns to the person, so it's coming from the external environment. And then gender expression is an interaction between the individual and their environment. So assigned sex or designated sex at birth, there's different language out there, really usually refers to the physical attributes that characterize maleness or femaleness. And generally that's based on genitalia, right? The baby's born, or there's an ultrasound, they see some genitals, and someone says, oh, that's a boy or that's a girl. Sometimes it might be based on a karyotype, especially if patients have disorders of sex development, or we have some questions about something going on for them, but generally it's based on the genitalia. Gender identity, in contrast, is a person's internal sense of self as female, male, both, or neither. So this is something that person's going to need to tell you, and so this is generally something that emerges when kids have language, right? So we can see gender nonconformity or gender diversity as early as age 2. So we have seen kids at that age express that they have a different gender than the sex that was assigned at birth. And that language then of course develops through time as they have development of their thinking ability and their ability to understand who they are. And so this is something that they're going to tell the outside world. So language is tricky. I'm not including all the words here that are used for this patient population. And some patients that are going to come to your practice are not going to identify with the words like I'm using here. So someone may not identify as trans, but I'm mostly introducing these words so that we have a language to use when we're talking about this population together. So my biggest piece of advice from this talk today is going to be that when you do meet someone, ask them how they best identify and let them give you the words that they use. But these are the words I'm going to use in this talk. So transgender is really an umbrella term that describes a gender identity that is different than assigned sex at birth. So if someone is trans male, then that means that they were assigned female at birth, but they identify as male. If someone's trans female, that means that they were assigned male at birth, but they identify as female. And then there's non-binary as well. So this is someone who might conceptualize himself as neither fully male or female, but somewhere on the spectrum in between. And there's many other words that people use. And then cisgender would be a gender identity that's congruent with assigned sex. And so, for example, I identify as a cisgender female. I was assigned female at birth, and I identify as female. So that would be an example. And then gender expression. This is the way a person outwardly communicates about gender. And it's important to recognize that messages about gender vary across cultures and time. So this is a picture that is of Franklin D. Roosevelt to illustrate this concept from 1885. And you can see that as a young child, he's dressed in what would nowadays be considered traditionally female clothing, but in that time was very common for all kids to be dressed. And so you can see how these messages that communicate gender concepts can vary. And even in one point in time, if you go to a different culture, you're going to see different messages. So it's important to tune into that and ask families, more about their culture and how, what the messages are that they're trying to convey, rather than make assumptions. Now, all three of these components can be conceptualized along a spectrum. And even this model is a bit simplistic, but I think it helps me at least understand that we don't view gender in any of these areas to be binary, meaning all of one or all the other. So for example, and someone can be at different places for these different components on the spectrum. So for example, you might have someone who was assigned male at birth, okay, so they had testes and a penis, and they were assigned male at birth, but they identify as female. But maybe when they're at school, they don't feel safe expressing that gender identity because they might get bullied at school. And so they might actually express themselves as more masculine or somewhere in between, like more gender neutral. So all of these components can vary at different places along the spectrum, and so that's important to understand. And it's also important to understand that gender identity is not sexual identity. And this is commonly confused. Parents get this confused, providers get this confused, the media gets this confused. So it's important to understand that when we're talking about someone's sexuality, that has its own set of components. Sexual orientation is more about, do you identify as like heterosexual, bisexual, pansexual, something else? Sexual attractions about the individuals that someone is actually attracted to, and that might be different than how they conceive their orientation. And then their sexual behavior can be something altogether different, correct? But these things are not the same thing as gender identity. Now we do feel that someone's sexuality and their gender interact. We're not separate pieces we're all one person. However, these are separate. So someone could be like a transgender male and identify as straight because they are attracted to females, for example. Any questions about any of the terminology? Okay. You guys are probably a very savvy crowd, so I'm going to blast through these things. So how common is this? This is one survey. We don't have great data, but the Williams Institute from UCLA analyzed data from a CDC survey in 2014 of 19 states. And the survey was administered to adults, and then they extrapolated the data to come up with youth estimates. but they estimated that around that in 2014 that there were about 0.7% transgender youth in the United States, and that would be 150,000. Since then, other surveys have come out, so school-based surveys and different ways to collect data, and they have come up with higher estimates. So I think a lot more needs to be done on the data collection to really figure this out. But this gives you an idea that this isn't something that's extremely rare. And so it's something that we need to be thinking about and that you'll probably encounter in your career. So gender etiology. So we think about gender identity and gender as being influenced by several things. Like most things, it's nature and nurture, right, as well as our culture. So I'm not going to go into all the studies on the biology of gender, but there is evidence that there are some roles for hormone exposure to the brain and various twin studies showing that there might be some genetic predispositions. However, a lot of other things also influence the development of gender, so that's something to keep in mind. And if you have an interest in this topic, let me know afterwards and I can point you towards the research. So why is this important? Why are we here talking about this? Well, it's important because this population, both youth and adults, is at risk for poor mental health outcomes and poor physical health outcomes, really. This is one example of a huge body of research showing this, but this is a retrospective Boston cohort of electronic medical record data, and it was pretty large. They looked at 180 transgender youth, and they compared them with 180 cisgender youth, and they found that there was a 2 to 3 increased risk for depression, anxiety, and suicidality for the transgender youth. That's pretty huge and very concerning, obviously. So there's many factors that influence this, and I'm going to go into that now. So what are the factors that influence the poor or positive mental health outcomes in this population? Well, we know that having parental support for their gender is critical. Having, promoting social transition, so this is really social support at school from their peers, from other adults, as well as their family. And then giving them access to gender affirmative health care are all really critical aspects to improve the health and function of this population.
There was a situation on the news the other night, I don't know if you're following that little boy who's 6 years old, who his mother is supporting his idea that he's a female, whereas his father's not. How, a child that young, can they identify that soon?
Yeah.
With gender, because he's a boy, but identifies as a female. So how do you address those issues?
Yeah, so it's actually a pretty, so the question is there was a young child who was 6 and he identified as transgender, and his mom supported him socially transition to his lived gender, and the father did not support it. The father was concerned maybe, that this would cause him to be transgender, or just didn't think it was the right thing. And the question is more about, what's the right choice in someone so young, right? It's a complicated question. So we do get kids like this in clinic, where they're saying that they're transgender sometimes from the age of 2 to 4. I've seen that too. And what I tell parents is that your kid is saying something, your kid is saying, I'm this, I'm female, I'm male, I want this, I want to use this name, I want to wear these clothes. And the most important thing to do for a kid that age is to allow them the space and to support their exploration of gender and gender expression. For some of those kids, they're actually not going to end up being transgender adults. They'll go through childhood, and possibly when they hit puberty and their body starts changing, they might decide that actually they're not transgender, and some of those kids will end up being, they'll end up being gay, or they'll end up having, just a cisgender identity. But some of those kids will persist. And so how do you sort out at the age of 6, which ones are gonna, persist and which ones are not going to? Well, the answer is you don't need to. The studies show that if you just allow them the freedom to express who they are, and you let them take the lead. You don't push them in any one direction. You just let them take the lead. That they end up having the space and the self-confidence to just explore this, and then they'll let us know as they grow older who they are. Okay. We do know that if we don't allow it, if we try to suppress it, that we don't allow them to wear the clothes they want to do, that they end up having behavior problems. They can have anxiety, they can have school issues, even depression. I've seen all of those things in very young children. and then allowing them to socially transition, came up with a relief of all of those symptoms. So I just tell parents, let them take the lead. Let's connect them with a therapist who does play therapy and can work with them throughout their growth and development, and we'll see where this goes. I don't need to do anything medical until they're much, much older, but we'll just, right now, just support, their expression. So this is a study that was actually based in Toronto, showing the impact of parental support for transgender youth, and it's really hard to read, so I'll kind of summarize it. But basically, they looked at 84 transgender youth who socially transitioned, and they compared the ones that had really high levels of parental support. So these were parents who let their kids take the lead. If their kids said, this is the name I want to use, they used it. If they said, these are the pronouns I want to use, they used them. And so the dark blue bars are the parents with strong parental support, and the light blue bars are the parents who said, no way, I'm going to use your legal name and gender, you are not allowed to socially transition. And on this side here, we look at the rates of positive health and function. So you can see with the dark blue bars, the kids who had high levels of parental support were much more satisfied with life. They had higher self-esteem, better mental health, and they were more likely to have adequate housing. So they stayed in their families and had adequate housing. And that's compared to the ones that had low support, which had much lower rates of those positive outcomes. And then on the other side, you have the opposite situation, so the rates of negative health outcomes. So you can see that the kids who had high levels of parental support had much lower rates of depression and suicidality. And that's what these graphs show. So basically this suggests that what parents can do and what really we can do when we interact with these kids is just reflect back who they are and let them take the lead with us. And then this study looks at mental health and self-worth in socially transitioned youth. So this was kind of getting to your question a little bit. This is a multi-center longitudinal study looking at socially transgender youth, and they compared them to age-matched controls as well as siblings. And they did child and parent reports on depression and anxiety, and then child self-reports on self-worth. And they found there was no difference between the groups in self-worth or depression. And this is huge. This means that if we just allow them to express who they are, that they have the same mental health as anybody else. So that's very important. And then access to care. So this is a Dutch study it's a very long-term study, and that's because the Dutch people actually started medical, systematic, multidisciplinary medical care of youth who have gender dysphoria. And they have socialized medicine, so they collect data on everybody. And they looked at 22 trans women and 33 trans men, and they evaluated mental health and well-being before starting puberty blockers, and I'm going to describe in a minute what that is, before starting estrogen or testosterone, and then after having gender-affirming surgeries, which happened after the age of 18. And they found that when they received all their treatment and they evaluated them at the end, that the gender dysphoria was relieved as adults, and that they had similar well-being and function compared to the general population. So they were equally healthy compared to everybody else. And that's an important outcome since this population is at risk. And then finally, this is a study looking at what are the perceived barriers from the parents and the children on accessing gender-affirming care. So we know it's important, but what are the barriers to accessing it? So this was a qualitative study looking at 15 youth and 50 caregivers, and they came up with several barriers. One was lack of accessible providers trained in gender-affirming healthcare. So that's one of the reasons why UCSF started a clinic here that is multidisciplinary. We have psychologists, social workers, medical providers. There was a lack of consistently applied protocols. So again, UCSF has developed protocols based on the clinical practice guidelines, and they're online for everybody to look at. Inconsistent use of patient's chosen name and pronoun. At UCSF, we have the electronic medical record, and I don't know if anyone's seen this, but at the top of the record, if you have someone who has a different gender and chosen name than what their legal one is, it will actually show up in the banner. So the chosen name will be at the very top, and you can put pronouns in there as well. And then below that, smaller, is the legal name, and so that you'll be able to, as a staff person, know immediately what name to use. Uncoordinated care and gatekeeping, limited access to medications and insurance exclusions for those medications. So how do we all here in this room address these issues? Well, we can all be part of this gender affirmative model of care. So that really means it's the process of having one's authentic gender affirmed and recognized across all four domains: social, psychological, medical, and legal. You guys will be intimately involved in the social domain. So in the social domain, affirming someone means that we use their chosen name. That when they come to clinic, we look in the banner, we make sure, we ask them, what, my name's so-and-so, what is your preferred name and pronouns? And then you use those consistently. And there's gonna be times where you might make mistakes. I make mistakes sometimes. And in my experience, if I slip up and I use the wrong pronoun, I usually just stop and I say, you know what, I'm sorry, I just used your wrong pronoun. And I'll try to do better next time, and then I move on. I don't stay a lot of time on it, but I do feel like acknowledging it and then making efforts to correct it going forward really shows that I think it's important, and it builds trust between me and the client. So I recommend that you think about that too. And then also just making sure that kids and adults have access to visual aids that show like gender diversity, that they have access to a gender neutral restroom. So they don't have to make the decision to walk into the male or female restroom, but there's something that's like for all patients. That can relieve a lot of anxiety with going to the bathroom. And having staff training, which is what we're doing today. So communication's huge. So I'm hoping that if you guys have any questions, you can stop me in this part. But I'd like you to imagine that you see a kid. Maybe they have appendicitis and they need to come in for an appendectomy. You walk in the room, you need to do a history and physical, get them ready for the OR. What I do is I generally will walk in and I'll say something like, "Hi, my name is Meredith. My name is Meredith Russell from Pediatric Endocrinology, and I use she and her pronouns. What's your name?" And then I let them tell me what their name is, because sometimes it also changes, so I don't always rely on just what's in the record. And then I let them tell me their pronouns, and then I reflect that back to them throughout the rest of the visit. The other thing you might want to think about is if you're going to be doing a physical exam, that you ask them if they have any words that they use for areas that you are sensitive that you might need to examine. And you may not need to, but like let's say you have a transgender male who has breast tissue and they're very dysphoric about that. They have a binder on, and you need to examine their heart or figure out some do something like that. So you need them to take the binder off. Rather than saying, I need to examine your breasts, you would ask, what words do you use for your chest area? And let them tell you, because a lot of times folks will give you a more generic term, and that feels more comfortable for them in describing their own body parts. Does anyone have any questions about this stuff, the language communication aspect? So at UCSF, we also want to make sure that we're affirming folks in the psychological domain. So that's really reflecting back their authentic gender. And so a lot of that has to do with communication as well. And also providing them access to gender specialists, which are therapists who are trained in supporting this population, evaluating them, helping them make complex decisions, like, what are the pros and cons of going on to medical transition, having body changes of estrogen or testosterone, exploring these kinds of things, exploring fertility concepts. So it's very important they have access, and so we at our clinic help people access that care in their community setting, and then they also meet with psychologists in our clinic. And then medical care. So we're very lucky at UCSF because we do have medical options for all the different ways that people may choose to transition. And not everybody's going to use all of these services, but we do have a clinic here, both primary care and specialty care endocrinology, where folks can access hormones, so estrogen and testosterone, and the puberty blockers. They can also access reproductive options. So we have a fertility clinic here at Mission Bay and other locations where folks can go and they can freeze their sperm or their eggs, get counseling on their fertility preservation. And that's really important because this often will become an important issue for them as adults. I find that adolescents are often, they have a difficulty sort of imagining wanting to have family and build a genetic child. A lot of times they'll tell me like, I'm planning on adopting. The parents are very much interested in fertility preservation, and when the client comes back in their early 20s or later, they often will say that they want fertility preservation. And then we also have voice and communication therapy. So for example, you might have like a trans female client who went through their own puberty and then ended up having a deeper voice. And that could be very unaffirming when they're using that to express their gender in the world. So we have speech therapists who can work with them, and as well as surgeons who can do surgeries as needed to help them achieve their goals. And then of course we have the surgeries. And so right now we have Dr. Esther Kim doing a lot of our surgeries in this population. We used to have another doctor who was doing surgeries, but he left. So I think this is an evolving area. And then in the legal domain, so we do help folks a lot with legal name and gender changes, and fighting with insurance companies to get approval for medications or for fertility preservation. So this is a huge component of the care as well. So I want to give you just like a basic understanding of like care that we're giving, so that you can kind of apply the ideas to clients who are coming to your practice. Our care is based on the clinical practice guidelines. So there's two main ones that we go off of. One is the Endocrine Society one, and that was most recently updated in 2017. And then there's another one that's more international focused, that is from the World Professional Association of Transgender Health. Both guidelines are available online, and they're what our Center of Excellence protocols are based on. One thing to keep in mind is that all the medications that we use are used off-label, and so that can be tricky with insurance companies. So what are the medical treatment options for these kids? So the main pathway that some of these clients will go through is puberty blockers, cross-sex hormones, which is estrogen and testosterone, and then finally gender-affirming surgeries, which is where you guys are going to come in. So we try to make very thoughtful decisions. Both guidelines have a similar approach in terms of criteria to access this care. So it's not enough for someone to come in and just say, I want to start estrogen, or I want to do this. We do have a process because we want to make sure that we're all making the right decision, that we've thought about all the right things. And so in order for someone to start a puberty blocking medication, the first thing they need to do is be in puberty, right? We don't give this medication, we don't treat medically young children. So the 6-year-old who's in the news, like we wouldn't give testosterone to or estrogen to, for example. And also we wouldn't give them a puberty blocker because they're not in puberty at 6 generally. We also have them meet with a gender specialist, so a therapist, who can talk with them more about their gender, and then they would be the ones who would make the diagnosis of gender dysphoria. And they would also make sure that we're teasing apart if they're, what's the gender piece, and and is that different or related to any other issues like depression or anxiety. So a really skilled therapist is going to be able to figure all that out. And then we go over the medications with the caregivers, and they will sign an informed consent form, and we get some baseline labs. And then for estrogen or testosterone, the guidelines state that we would start them at the typical age that youth are able to make complex decisions, which is thought to be achieved by age 16. However, we often will evaluate a young person, and if they're able to make that decision at a younger age, like 14 for example, then we will consider starting it at that age. And that's important because if you wait till 16 to start estrogen or testosterone, then you're well past the usual time of puberty, and they can feel really left behind compared to their peers. And then in terms of like genital surgery, generally that's done at 18 or over. There are surgeons in San Francisco in private practice who do it in younger kids. So you might run into that. You might see a client who had like a vaginoplasty, like a new vagina made at the age of 16, for example. So this is evolving. And then for chest reconstruction, that is often done anytime after the age of 15. So you're definitely going to come across that. So to kind of help anchor the rest of the discussion, I have a couple cases. Case one is Nicole. So she is a 10-year-old, and she was assigned male at birth, but very early in life reported that she has a female gender identity. She presents to your practice. Maybe she's, again, she has appendicitis and needs an appendectomy. And she's wearing a dress, traditionally female hairstyle. She's also very distressed about recent signs of male pubertal onset. So she's seen in our endocrine clinic, and she says that she's been a girl since age 2. The parents are like, yeah, we remember this, ever since she could basically talk, she said that she's a girl. And they assisted her with social transition in kindergarten, and that relieved a lot of the anxiety and behavior issues that she was having. And she's noticed that her testes have started to get bigger, and she's really freaked out that she's gonna start having like voice changes or hair on her face. So she's going to be diagnosed with gender dysphoria, and this is a mental health diagnosis currently related to the distress or impaired functioning related to the incongruence between one's gender and the assigned sex at birth. And this may result in body dysphoria. So what I do see in a lot of these kids is they might feel very, very uncomfortable with their genitals, or if someone's developed breast tissue and they're male, they can be very, very uncomfortable with that part of their body. And some people will actually do cutting or self-harm because of this discomfort. It can be very, very difficult. I've also seen eating disorders crop up because they're trying, in some cases it seems related because they're trying to modify. So if you, for example, if you have a trans male who is having menses, they might stop eating in order to make the menses go away and also to make the chest appear smaller. So we definitely screen for self-harm and disordered eating in this population. And then whether Nicole is getting a physical exam in our clinic or they're coming to you to get a physical exam for surgery, this can be a very stressful experience. They may not know what's going to happen, and if you're thinking about looking between their legs, that might be very traumatic for them. So what I recommend is that before you jump in there and do an exam with any of these kids, that you try to establish a trusting environment by using their chosen name and pronoun, also letting them know why you want to do the exam and what the exam means, what you're going to exam, and then using general terminology for body parts so that you don't make them feel even more uncomfortable. And whenever possible, provide choices, involve them in the decision for like how they disrobe or what's going to happen when they go into pre-op, because the more control they feel they have, the less anxiety they're going to have. So Nicole is eligible for puberty blockers. We find that she is in puberty, her labs show it, her physical exam shows it. What are these medications? So we've actually been using puberty blockers, which are gonadotropin-releasing hormone agonists, since the 1980s in kids with early puberty and since the 1990s for gender dysphoria. There's also some adult indications, and they come in 2 main flavors. One is pictured here, which is like an implant. It's similar to the birth control implant, but instead of the birth control medicine, it's got the puberty blocker in it. The implant is FDA approved for a year, but generally lasts 2 years. And then there's also injections available, and I usually use like the 3 or 6 month formulation for that one. And that goes in the muscle. These medications are going to be most effective if they're started early, and that's because you're going to avoid the undesired body changes of puberty that will then require surgery to correct later. So for Nicole, she's in stage 2, so her testes have just started to enlarge and she's got just a little bit of hair. That's too early for her to have voice deepening. So usually the voice deepening doesn't happen until stage 3, for example. And then on the, for someone who is assigned female at birth with a male identity, you're not going to have your first period until about stage 3 as well. So if we can block someone early, then we're going to avoid a lot of, unwanted body changes. I'm going to skip through the mechanism. So in terms of administration, has anyone assisted in a case with a puberty blocker? Has anyone seen this done? So it's done both in the OR and also we do it outpatient. It's more likely to be done in the OR if someone's young. So the precocious puberty kids typically get it done in the OR under general anesthesia. Or if there's a kid who has like severe needle phobia, then we do it that way too. Otherwise, I actually administer it in the outpatient setting with Child Life and sometimes Ativan. But basically it just involves numbing with lidocaine if you do it in an outpatient setting, making a small incision, and then using this tool that you can see to insert the implant. And then I usually just will close with skin glue and steri-strips, although sometimes I think in the OR they might use stitches. And there's 2 different brands. One's for adults, one's for kids. They both work the same. and they're actually made by the same company. So what are the pluses and minuses of these medications? Well, we already talked about how it can reduce need for later surgery, which will take away some of your business, but it'll be good for the kid. It also can buy time if someone has a non-binary identity or doesn't really know their path. So it could be that like that kid who's 6, you know, maybe they go along in life, they hit puberty, but they're still not yet ready to make a decision about, you know, which pathway they want to go down. You can do a puberty blocker, which is totally reversible. So if you stop it, everything just wakes up again, and you know, for a period of time, and that can help the kid then develop and work with the therapist. Now, what are the downsides? Well, these medications are extremely expensive. When you're on them, you build bone mineral density at a pre-pubertal rate. So that's the rate that you build it from like infancy until you hit puberty. But you don't build it at the faster rate, which is under the influence of sex steroids, estrogen or testosterone. So what this tells us is that you can't be on a puberty blocker by itself forever, because you build your peak bone mineral density through your adolescence until your mid-20s, and then you're done, right? So you've got to have a sex steroid at some point. And then fertility, right? So if you go on a puberty blocker and then you start a cross-sex hormone, and you've never like frozen eggs or, you know, gotten or sperm, then you're going to have limited fertility options. This is just to illustrate the power of these medications. So these are actually 46XY identical twins, well known in the media. And Nicole here on the left had a female gender identity, and so she ended up going on blockers, you know, once she hit puberty, and then she actually has gone on to take estrogen, and she's an adult now. But her identical twin brother here, Jonas, entered into puberty, and you can see that he's got an Adam's apple, that he's got widening of the nose bridge and a squaring of the jaw, and then some hair on his upper lip. So he's developing very different characteristics compared to Nicole. And if Nicole didn't have access to puberty blockers, then she would look like her brother, and then she might be coming for surgeries when she's older. So Nicole is now 14 years old, and she's coming back to clinic because she wants to start having breast development. She wants to be in line with her friends. All of her friends are menstruating already. And you determine that she meets criteria. She might also be doing some non-medication methods to help her feel the most comfortable in school. So for example, she might be doing tucking, which is where you take the testes and you put them in the inguinal canal, and then you tuck the penis between the legs, and then use something like a gaff, which is what pictured here, to like squish everything down. Some people will use paper tape. I strongly discourage like duct tape or things like that, because that can lead to a lot of problems. We talk about removing this at night. We talk about the risk of skin irritation. We talk about you know, reduced fertility, and we also talk about the possibility of developing hernias if you've got very large testes that you tuck into the inguinal canal. So those are some of the risks of that. And then also Nicole might be using you know, padded bras or breast form, things like that. So if these kids are showing up in your clinic and it's time to do a physical exam, it's helpful to ask them how they would feel comfortable getting into a gown, for example, because they might have some of these things in place. And so you might need to make a plan for that. So we're going to start Nicole on estrogen, and we use bioidentical estrogen for hormone replacement. We don't use birth control pills, which is ethinyl estradiol. We use 17-beta estradiol. So it's got similar risk factors as someone whose body makes it, and it comes in patches that you can wear on your skin and change, you know, a couple times a week, or pills that you can take every day. And we start at a beginning puberty dose and then increase over time. Estrogen's going to have some body changes, so the irreversible ones are the breast development. It's also going to, when someone's on estrogen and a puberty blocker, you're also going to have you know, reduced sperm production, or if they're on a puberty blocker, it'll be completely eliminated. And then she'll also develop, you know, body fat redistribution, you know, collecting fat in the chest and hips area, skin softening, things like that. So what are the potential adverse outcomes of estrogen? So the main one I focus on is actually the first one, thrombosis, so blood clots. That is much higher with ethinyl estradiol. So the synthetic estrogens, you know, like we always learn, like birth control pills, which is ethinyl estradiol. You know, women over 35 who smoke cigarettes and are on those have a risk of stroke and blood clots. With someone who's getting hormone replacement therapy with bioidentical, the risk is much, much lower. So the question we get a lot is like, do we hold the estrogen before surgery? And in most cases, the answer would be no. You would want to follow the usual protocols for preventing blood clots in the OR and after the surgery. But in most cases, it's not necessary to withhold these medications because they're on doses that are going to give blood levels of anybody whose body makes estrogen at that age. Okay. These other things are also possible risk factors of estrogen. Most of these are really a main risk of the higher dose synthetic estrogens. So, but I do list them here. And I think about that more for people who have like other medical conditions, like you're a trans female and you also happen to have a risk for heart disease. So what are some of the surgeries that Nicole might choose, or someone who maybe, especially if they went through a puberty that they didn't desire? Nicole might choose to have breast augmentation when she's older. I generally discourage this until someone's been on estrogen for at least 3 years, because you're going to have a lot of development in that first 3 years. And then if someone's not happy with what they have, then they might have this procedure. And so you might see this at UCSF. It's considered medically necessary and not cosmetic surgery. Nicole might choose facial feminization surgery if she hadn't had puberty blockers and she looked like her brother, the twins that I showed you. And that's surgeries, trying to feminize the face more. She might choose a tracheal shave. That's not the correct medical term, but that's the one that all the clients use, so I put that here. And then she might also choose genital surgery. So the most common one I see is vaginoplasty, and that's where use the scrotal skin and the penis skin to like do an inversion and create like the opening of the vagina. And sometimes, especially if there's not enough tissue to be used because someone was blocked early in puberty, they might have to use tissue from other areas like the colon, the bowel, or something like that. So these are just some surgeries that you might come across. And then my final case is Jacob. So he is 14 years old. He is assigned female at birth, but he has a male identity. He's gone through a female puberty, so he's gone an estrogen-mediated puberty, and so he's got breast tissue, he's menstruating, and it's very uncomfortable for him. His parents are supportive. He meets all the criteria for treatment. So we're going to talk with him a little bit about some of the things he's using. He comes to your surgery practice, and he might be wearing something called a binder, and this is a really tight, stretchy garment, and it's pictured here, that sort of squishes down the chest tissue. And some people will also use things called kinesio tape, which is like this stretchy, waterproof tape to do it, or unfortunately ace bandages, things like that. But most commonly I see the compression garments. We do talk about wearing these less than 8 hours a day. I have seen, if someone leaves it on a long time or has it too tight, I have seen costochondritis, so inflammation of the ribs, and sometimes it can impair, breathing and cause severe pain. I've had a patient actually end up in the emergency room with this. So in those cases, they have to remove the binder and then go without it for a while to recover. But this is something that someone might show up with, and then if they're going to be going into the OR and you don't want the garment on there, you'll have to make a plan with them about how that's going to be removed and help them feel as comfortable as possible, because it could be very upsetting for them to not wear it. And then Jacob might also be using a penile prosthesis, and some of them you can use to pee through in a bathroom, and some of them are just used to make a more masculine silhouette. And then for Jacob, we're also going to start testosterone. So generally, the most common way to do it is going to be injectable. So we're going to start him on weekly subcutaneous injections, and it increases dose over time. There are other ways, so he might be on daily gels or patches. And then I also do an outpatient procedure where I insert subcutaneous pellets that dissolve into the upper butt, essentially, or the hip. And those slowly dissolve over time, and they last up to 6 months. So again, the testosterone is going to have pretty rapid and potentially irreversible body changes. So in the first 3 to 6 months, I already noticed things like, a deeper voice. And then once the voice is deep, if you stop testosterone, it stays deep. you'll already start to notice increased body hair. If someone stops testosterone, the hair continues to grow. And then over time, if you're on testosterone for 1 to 3 years, you're gonna notice the development of an Adam's apple and those face changes that you noticed in the twin study. And you're also gonna notice enlargement of the clitoris. So some people will see that when they do an exam with these patients. And then there's some reversible things like the menses go away, and a lot of times people have increased libido, those kinds of things. What are some things to think about when, in terms of surgery? So when someone's on testosterone, it can increase the red blood cell count. So that's the erythrocytosis. What I do tell people is that a lot of times we monitor the CBC as when someone's on testosterone, and if they haven't done a legal gender change, their gender is listed as female, and then the lab will post the female reference ranges, which are lower. So testosterone always makes the red blood cell count increase, but you just don't want it too high. And so what I tell people is make sure that if you're looking at lab results, that you know what the male reference ranges are, and that you don't make a decision based on the female ones. But if someone has too many red blood cells, it increases the risk for clots, okay? So that's something to think about. In our patients, we do hormone replacement, so we don't do high doses, but in particular with adults, they often will encourage their providers to go as high as possible because they want rapid changes or they want to work out and build lots of muscle. And so I sometimes see very high doses of testosterone, and then this risk becomes very real. And so if they're gonna have a surgery, you would definitely want to have a CBC before they have the surgery and make sure that they don't have that risk. And some surgeons will just have them stop the testosterone for 1 or 2 weeks before the surgery. So Jacob, he's on testosterone. His periods went away. He's thrilled about that. His voice is deeper. He's starting to get a little bit of hair on his upper lip. However, he's really dysphoric about his chest tissue, and he's been wearing a binder for a long time, and it causes him pain, and he can't work out in it. So he's interested in having a surgery. So what are his options? So there's different words that are used for this kind of surgery. In the community, most people right now are saying chest reconstruction. That feels pretty affirming for a lot of the clients. And so I usually will ask them what word they prefer, but that's generally what I'm hearing right now. Sometimes you'll hear top surgery, and then surgeons will have the technical term. So it'll be a mastectomy procedure. And then the guidelines do suggest that genital surgery is over the 18 years of age. I'm not gonna go into these genital surgeries, especially phalloplasty. It's actually not very common in our patients right now because the complication rate is pretty high. There's a big risk for fistulas and all kinds of different complications, and so I actually see vaginoplasty way more often than I see phalloplasty. But I do see chest reconstruction all the time. So there's different procedures that you can do for chest reconstruction. So these are some examples. So if someone has a smaller cup size, like a size A or something like that, they could do this one here on the left, and that's where they make an incision around the areola, and then they go in and they basically, vacuum out the fat tissue and the limited glandular tissue, and then this one is very desirable because you can see the result here. Once the scar heals, you can't see anything, so it just looks like any other guy. But if someone is larger, like B+, then the most common surgery is going to be the double incision. Sometimes it will be just a single incision across the front, but that's where the surgeon really they have to move the nipples areola, they have to make the incision, they go in there, take all the tissue out, and then you're left with having these scars kind of below here. And with these patients, they're gonna have drains in most often, so they're gonna have 2 drains on the side, and those drains will stand for typically about a week, and that's to prevent edema. And they're gonna be on pain meds post-op and all of those things, with the usual post-op potential complications like infection. So in summary, transgender and gender diverse youth have increased risk for poor mental health and function. However, all of us, as well as parents and school staff and really everyone in the community can have a huge impact on these outcomes. So the more that the more positive experiences they have with you guys as healthcare providers, the more likely they're gonna be able to feel comfortable showing up for care when they feel sick, or they're gonna have lower risk of anxiety and depression. we do need to have more research on the best treatment approaches and the long-term outcomes. We have several studies here going on at UCSF, as well as multi-center national studies looking at the long-term effects of the medications we offer and the treatment approaches. This is probably one of the most uncomfortable aspects of this field for me, is that we talk a lot about evidence-based practice in medicine, right? And in surgery, like, that's a huge thing. But we really don't have a lot of evidence for some of these things. And so there's a huge amount of research going on right now. But what we do is we operate on the best evidence that we have, and then as time goes on, I'm hoping that we're gonna be able to provide even better care. So, yeah, in the back.
Does it ever happen that someone goes through with some surgery, or they start to transition and they're like, I wanna go back?
So the question is does anyone ever like regret, their transition later on and maybe go back to the gender they were assigned? And that, I'm sure that happens. When you look at the studies, so that there's this one study that's a very large, well-known survey of adults by the I think it's the National Center for Transgender Equality is the body that does the survey. It was an online survey of like thousands of people. I think it was like 27,000 people. The rate of that is extremely low. So most people don't decide later on to transition back to their gender. What I do sometimes see is medication fatigue. So this is like someone who has been on like testosterone for like years, and they're sick of doing shots, or they're sick of doing gel, and they'll come to me and say, hey, I just wanna like wean off of this, and they're gonna have the hair development, they have the deeper voice, people are gonna gender them as male, and so sometimes they feel like, well, that way I won't have to do anything. And as long as they have their ovaries in their body, they can do that because they'll start making estrogen, and that will protect their bones. If they've removed their ovaries, they cannot do that. But I would say invariably they often come back later and ask to go back on it because they feel better on it, and they're more affirmed by having that hormone. So I think it's very rare. Where I do sometimes see like different twists and turns in a journey is more with the non-binary folks. So these are folks who don't identify as exclusively male or female, and some of them will have different gender pathways as they get older, and some of them will do like hormone therapy for like a year, and they get some body changes that they're looking for, and then they stop because they're just looking for like a deepening voice, or they're just looking for a little bit of something, but they don't want to fully transition. And so the whole non-binary group of folks is really educating me on how gender identity development can be a lifelong process for people. I haven't had anyone to date come back and say that they regret any of the choices that they've made. I've had people come back and say like, this was all part of my journey. So, and that's true for even the non-binary folks who've done like testosterone for like a year, for example. They come back and they're like, I'm so glad that we had this care and that I did this. I don't need to take it right now. So,
I'm just curious about what's your take onto the transgender male competing to the women sports.
Okay. Well, so the question is more about, what are the considerations of someone who was assigned one sex at birth, has a different gender identity, and then also is an athlete. So, for example, is participating in high school athletics or adult athletics. So there are actually laws and policies that outline what can or can't happen with those athletes. So for example, if someone is participating in a woman's sport, but they were assigned male at birth and they identify as female, in many cases they have to have a blood test to check their testosterone levels, and the testosterone levels have to be in the female range. And that's because testosterone is a performance enhancer, so it increases your muscle mass, your sports performance. And so the main issue there is they don't want those athletes to have an unfair advantage compared to the other females. So I actually sometimes have to write letters about this and say so-and-so's testosterone is in this range, and they're on these medications, and then they're able to compete in this sport that is in line with their gender. So there's laws and policies in place to provide folks with a pathway to participate in these sports. And it's an evolving field. I think there was an athlete in the news recently that actually had elevated testosterone levels and didn't want treatment for it, but also identified as female. And so that they were very upset that they couldn't participate because of the elevated testosterone. They considered that like a medical problem that they didn't want to have to change it. So I think it's an ongoing discussion. But in terms of my clients, I sort of help them understand the laws and policies, and then get them to where they need to be so they can participate.
The surgery and medication covered by insurance or?
So the question's about insurance coverage of these medications and surgeries. So when the Affordable Care Act went into effect, there was a portion of it that basically said you can't discriminate against people based on sex or gender, and that was interpreted by the Obama administration as meaning also transgender people. And so once that Affordable Care Act went into place, suddenly insurance companies had to cover the medications and surgeries because both are considered medically necessary, and clients before they have the surgery or start medications often have to get a letter. Well, for surgeries, they have to get a letter from the mental health provider saying they're transgender and that this is a medically necessary surgery, and then I write a medical letter as well. So they're considered medically necessary. They are mostly covered. However, there are 40 states currently that allow insurance exclusion clauses in their plans. And so while there's this federal umbrella that protects these patients, there are states that allow the exclusions, and so the insurance policy, will actually write in like, we cover puberty blockers, testosterone, and estrogen for everyone except for transgender care. And it's really horrible, and then we go into these cycles of appeals and fighting with insurance companies if they have those kinds of plans. But in California, this is one of the better states to be in. There are very clear laws in California that prevent any state-sponsored insurances from doing that. So like Medi-Cal, Medicaid, they cover all of these surgeries and the medications. But where you get into trouble is like these employer-sponsored plans. Some of them might have still insurance exclusions, and that's where you get into like the legal stuff. And so occasionally families have to hire a lawyer, and it gets ugly. But yeah, it's an evolving situation. And of course now with the new guidance under the current administration with how to interpret the Affordable Care Act, we're all kind of wondering what's going to happen. So. Any other questions?
Thank you.
You're welcome.
Thank you.